With DL, we spend a lot of time talking about inserting the blade off to the side and sweeping the tongue out of the way. With VL, you're using a wider blade. Insert the blade to the midline. Next, because one of the difficulties with video laryngoscopy, since your eyeball is essentially down here, is that if the patient has a spooged airway, if there's vomit or blood or whatever else they might have in there, and you just insert your camera right into the muck, you can foul your view, have to come out and start from scratch. So it's best to try to avoid that. So my recommendation is you put the blade in just a little, just put the tip in, keep it in midline, and then once you can see what's in the airway, gradually walk your way down the surface of the tongue until you get into the vallecula. So what you're trying to avoid is blindly putting the tip of the device into the vomit, and you're also trying to avoid the dependent surfaces in the airway where the mucus and blood and beer is going to go. So that stuff is going to fall down to the posterior surface of the airway. You want to make sure your camera stays anteriorly. So start with a midline insertion, and what you want to do is just walk down the tongue.